Okay, great. Well, thanks for having me. I want to thank Stephen Shore for putting this wonderful conference together, and I want to give a special shout out to John Papadopoulos, who, with skill and great patience and humor, gets my tech going. And I'm glad he's standing by. I want to start out by telling you a story, a true story that happened to me on November 19th of 2022. I had developed a serious cardiac arrhythmia. I was having recurrent ventricular tachycardia, and I was having it for about 7 years. And I had 3 ablations. They didn't last. And that my clinical condition was getting worse, and I was stuck in ventricular tachycardia in a hospital bed on a high dose of intravenous lidocaine. Things were getting pretty serious. And I had a wonderful procedure by 2 world-class electrophysiologists. One electrophysiologist went in my femoral vein the way an ablation is usually done, and the other one went through my chest wall with a catheter that could be threaded into the pericardial lining of my heart. And the 2 electrophysiologists together were mapping the source of the ventricular tachycardia and doing it. They could do it because there were 2 sensors. They could do it in 3 dimensions, and they could find out how deep in my heart tissue the aberrant signals were coming from. And they ablated the aberrancy. And since then, the last 6 months, I've not had any problem. And it appears that they cured me, and my life was in serious danger without that procedure. I was lying in the ICU the day after the procedure, and a cardiologist, not an electrophysiologist, but a cardiologist came by to make rounds. And he pulled up a chair the way good doctors do. And he knew that I knew something about statins, and he wanted to discuss the issue with me, cholesterol lowering and statins. And he wanted me to take an additional drug called Vytorin or ezetimibe to lower my cholesterol further, even though the problem that I was having didn't have anything to do with cholesterol. And I was looking at him in the chair that he had pulled up to my bed, and I could see him with one eye, and I could see the cardiac monitor with the other eye, and I didn't know whether I was cured or not. And I could see, as I was talking to him, I could watch and see on the monitor whether the premature ventricular contractions were recurring and whether I was in danger. And he suggested that I take more cholesterol-lowering medication. And I said to him, I know the study you're talking about. It was published in the New England Journal of Medicine, but they didn't choose the right endpoint. The endpoint they chose included revascularization procedures, which are subjective and can be determined or affected by a patient's level of LDL. And those patients who have higher LDL are more likely to have revascularization procedures. So the studies that include revascularization procedures in the outcome of heart attacks, strokes, and cardiovascular deaths are diluting the message that's coming about the drug that really benefits people. So I said to him that, and he responded, well, I understand that, but the drug company, it would be very expensive to do the study the other way because there wouldn't be so many endpoints. And I said to him, I can understand that, but it's the drug company's responsibility, not the patient's responsibility or the doctor's responsibility to do the study right. So we didn't quite get to agreement there, but I'm looking at the monitor. I'm still doing okay. And I said to him, do you know that when a paper is published in the New England Journal of Medicine or the JAMA or any of the other respected journals, and it's peer reviewed, do you know that the peer reviewers don't get to see the actual data, that they're relying on the manufacturer's presentation of the data in most cases? And he sort of sheepishly said, yes, I do know that. And he tried to mitigate the importance of that by saying at the New England Journal, they require that clinical trialists submit protocols and statistical analysis plans so that there's some check to make sure that the study's been analyzed properly. And I said, but that's all good. But if they don't have the data, it's not really evidence-based medicine, because you can't have evidence without data. And then my cardiac monitor was okay. I was having no PVCs, and I figured I might as well keep going. So I said to him, how can you possibly present yourself as a learned intermediary, telling your patients and your colleagues and the people who respect your cardiological expertise, how can you possibly present yourself as a learned intermediary when the evidence that you're relying on, has not been independently evaluated? And at that point, my monitor was still okay. I'm not sure the cardiologist was feeling so good. And we decided to end the conversation. But there I was in an ICU, modern medicine having saved my life. And this very competent academic cardiologist is acknowledging to me that what he's accepting as evidence-based medicine has not been independently vetted. And that is a major part of the core problem that I'm going to talk to you about today. Just conflicts of interest. I'm the author of Sickening: How Big Pharma Broke American Healthcare and How We Can Repair It. And in the past year, I've served as a plaintiff's expert in litigation involving Celgene and the drugs thalidomide and Revlimid, and in a case involving GlaxoSmithKline about the diabetes drug Avandia. So I want to present an overview of what I'm going to talk about, and then we'll get down into the details. But before I do that, I want to say that this lecture, or previous iterations of this lecture, I've presented to a group of 50 PhD students from Harvard and MIT in their science and health technology program. These are very sophisticated, very smart, and intellectually not bashful folks. And I presented it a month ago to the University of North Carolina in Chapel Hill Department of Medicine Grand Rounds. So this is what I'm going to show you is not watered down. And I don't want to scare you and think that I'm going to be talking over your head, because it's going to be a lot easier for you folks to understand what I'm saying than it is for the people who are being brought in, indoctrinated might be slightly too strong a word, but brought into the medical world and being taught what they should accept as legitimate information. And I think you're going to see that this is so contrary to common sense and decency, but you'll be able to see it much better than the practitioners of medicine. So I'm going to present you an overview which will compare Americans' health and healthcare to that of other wealthy nations. And then I want to dive into my area of expertise, which is how the pharmaceutical industry is changing the sources of information that are available to doctors, and how they are doing that with the primary motivation of maximizing their investors' financial return on investment, not the American public's health or our economic well-being. So the largest unrecognized cause of doctors and other healthcare professionals' belief about optimal care being taken away from an epidemiologically balanced approach to healthcare and a factually based approach to healthcare, the largest impediment is that the drug companies and commercial interests are manipulating the knowledge that is presented to doctors and other healthcare professionals in the way that they've been taught to receive it. And fundamentally, there are two issues. What is the new knowledge? And notice the quotation marks around knowledge. What is the new knowledge about? And let's define knowledge as a justified true belief. We're not talking about knowledge as 2 + 2 = 4. It's not absolute knowledge that doctors rely on. The knowledge that they rely on is created in a social context, the fundamental purpose of which is to maximize those financial returns to the investors. But doctors are taught to accept the so-called evidence-based medicine that's presented in peer-reviewed journals even though the peer reviewers don't get to look at the data independently. They're taught to accept that as knowledge. And we want to keep in front of mind that what they're accepting as knowledge may not be true knowledge. And then secondly, so what is the knowledge about? Is it about the right thing? And then secondly, is the knowledge that's being presented to them accurate and reasonably complete? And then finally, at the end of the lecture, I want to talk briefly about meaningful reforms, which have to improve the epidemiological balance of the knowledge base that is brought to them, and has to improve the trustworthiness of the scientific information that they have to accept as the evidence in evidence-based medicine. And before those reforms can be even begun to be implemented, we've got to figure out all together, how to overcome the powerful resistance of the commercial status quo. So let's start with just a quick view, 4 perspectives on ethics, because there are ethical presumptions in what I'm going to say. And I think we can all agree on these general statements. The first, from Confucius, from 500 BC, he states it in the negative. He says, "What you do not want done to yourself, do not do to others." If you don't want to get drugs prescribed by doctors based on false information, don't create false information and give it to doctors. Matthew 7:12 says it, flips it, and turns it into a positive statement. So whatever you wish that others would do to you, do also to them. For this is the law and the prophets, the golden rule. Immanuel Kant made the same kind of ethical statement, not based on religious principles. This is his categorical imperative. Act only according to the maxim by which you can at the same time, act only according to the maxim by which you can at the same time will that it should become a universal law. Act in a way that would work if we all acted that way. And then finally, John Rawls wrote a book, A Theory of Justice, in 1971, and he put forth the notion of a veil of ignorance as a way to determine what would make a just society. And he proposed that social policy should be made by people who don't know what their role in society is going to be when they start to live in the society they've designed. So in this talk, I'd like you to think about maybe we have a drug company CEO and a researcher and a doctor and a patient and a taxpayer all at the table. And we're going to try to figure out the best way to help doctors to understand the best way to take care of their patients. So let's just use that as a background that we'll think about what's the issues that I'm going to discuss. So first, an overview of American medicine, and I'll be very interested in the questions afterwards. If somebody or if folks could tell me how much of this they knew already, and how much is new material. So if you're going to ask a question after I'm done, please note the slide number. The slide number is down here in the lower right corner of the slide when you ask the question. And I think we all know that American healthcare is not living up to its potential, and it's very expensive. But I'm going to fill in some of the details here. So this is a graph that looks at life expectancy here on the vertical axis between 72 and 86 years. And it looks at the years between 1980 and 2021. And it plots life expectancy at birth. And the green line is the United States, life expectancy in the United States as the years go along. And the blue line is life expectancy in 10 comparable countries, wealthy countries. And you can see in 1982 is an important year to me because that's the year I hung out my shingle and started my family practice. And the United States was almost up to the other countries. It was 0.6 years behind in life expectancy at that point. And you can see how these curves separate as time goes on and then separate acutely at the very end. And I want to divide these years into three different periods. Between 1980 and 2014, we were living 0.6 years less than the citizens of other wealthy countries in 1982. And by 2014, we were living 3.3 years less than the citizens of the other countries. So we know we're spending a lot of money and we're losing ground. Then we get to the period of 2014 to 2019. Now, this is a very informative period because approximately a third of Americans were uninsured. 17% of Americans were uninsured. And when Obamacare was passed in 2010, but it didn't come into effect until 2014. There were 42 million Americans who were uninsured when Obamacare came into effect in 2014. By 2019, that number had gone down to 28 million Americans. So about a third of the uninsured Americans got insurance during those years. And that's a good thing. We think everybody should have insurance. But look what happened. Life expectancy did not go up. The economy was growing in the United States. We were doing well. Obama was president through 2017, and then Trump took over, and we had a strong economy. And yet, despite America's spending, our life expectancy wasn't going up, while life expectancy in the other countries was going up. So then we get to 2019, just before the COVID pandemic starts, and here we go, 2020, 2020 and 21, and we see that life expectancy in the other wealthy countries declined in 2020, and then it went up and recovered most of the way in 2021, whereas life expectancy in the United States just took a nosedive. So we were 3.4 years behind the other countries before the COVID pandemic, and we were 6.3 years behind the other countries after the second year of the pandemic. Americans were living 6.3 years less than the citizens of the other wealthy countries. Now, this is data from 2021. Here we see the other countries are living 82.4 years average. We're living 76.1 years. That's a 6.3 year difference. And to achieve our 6.3 years less of life expectancy, we're spending $12,900 per person per year. And the average of the other 10 countries is $6,000 per year. Now, this is an enormous amount of extra spending. If we subtract 12,914, is 6,003 from 12,914, we're spending $6,911 extra for every American every year on healthcare. And if we multiply that number by $334 million, it shows that we are spending an excess $2.3 trillion a year. That's like 3 times more than the Defense Department budget. We're spending an excess $2.3 trillion a year. And the result, the effect on our health is that we're losing so much ground that Americans now live more than 6 years, that lifespans are more than 6 years shorter than the citizens of 10 other wealthy countries. Now, that's bad enough, but I think it's important to look at the equity of the situation. And the blue line is life expectancy in 2019 before the pandemic. The aqua line is 2020, the first year of the pandemic, and the green line is 2021. So for white Americans, they started out in 2019 with a life expectancy of 78.8 years, and it went down 2.2 years in the first 2 years of the pandemic. For Black Americans, they started out at 74.8 years, 4 years less than white Americans, and it went down not 2.4 years, but it went down 4 years during the first 2 years of the pandemic. And for American Indians and Alaskan Natives, they lost 6.6 years of life. So not only is overall American longevity poor, but the less fortunate among us, the minorities among us, are getting the short end of the stick, and their health is much more vulnerable to something like the COVID pandemic. Now, we might feel comfortable if we're wealthy, if we're lucky enough to have a college education and a professional job, and we're able to read, we have the skill and the training to read medical information, that we're in a good position to get the best of American healthcare and not get the worst of it that's dragging down our numbers. Here's a very interesting study that compared health outcomes in white citizens, wealthy white citizens, to those of average Americans and the average citizens of the other 10 countries we've been referring to. And what the first part of what they found is not surprising at all, that white citizens in the wealthiest 1% and 5% highest income counties have better health outcomes than average Americans. No surprise there. But here's a surprise. The white citizens who live in the 1% and 5% highest income counties have worse health than the average citizens of the other 10 wealthy countries. The citizens, we have worse outcomes for infant and maternal mortality, colon cancer, childhood acute lymphocytic leukemia, and acute myocardial infarction. The wealthy white Americans have worse outcomes than the average citizens in the other countries. So this is a slightly more refined way to look at longevity. This is overall age-adjusted mortality rate per 100,000 in the population between 1980 and 2017. And the reason why this is slightly more accurate than simple longevity is that different countries have different age populations. So Italy's population is quite a bit older than the United States', and they're going to have a higher death rate. But the World Health Organization creates standardized population age distributions for population, so that when you look at the death rates and correct them for the standardized distribution, you can make an accurate comparison of the death rates between different countries. And now, again, we're comparing the United States is green, and the 10 wealthy countries are blue. If we go back to 1980, we can, let me show you. If we go back to 1980, the death rate in the other countries is higher than ours. And if you subtract the death rate in the other countries from ours per 100,000 citizens and multiply that by 334 million Americans, 194,000 Americans fewer died in 1980 than would be predicted from the average age-adjusted mortality rate in the other countries. But if we come out to 2017, long before COVID ever hit, we see these lines have crossed. Now the green line has a higher age-adjusted mortality rate. And around 1987, it went higher, and it stayed higher and kept getting higher long before COVID hit. And the age-adjusted death rate in the United States was 840 per 100,000, minus 693 in the other countries, times 334 million people in the United States, shows that in 2017, almost 500,000 excess deaths occurred in the United States because our health and healthcare is so inferior to the other wealthy countries. Now, I want to put 500,000 deaths a year in perspective. COVID was terrible. It was the worst health crisis that I've seen in my lifetime, which is going back further and further. And COVID caused 1.1 million deaths in 2020, 21, and 22. It caused 1.1 million Americans to lose their life. But just because our age-adjusted mortality rate is so much higher than the other countries before COVID, more than the death rate from just the disparity in our health and healthcare is 50% worse than the entire death rate from COVID in the United States. So this is an enormous, I mean, we heard COVID on the headlines every day, and we should have, but we should be hearing this every day 50% more, because this is taking 50% more lives than COVID did at its worst. And I find this just completely shocking. And then this is kind of the last straw. This is a complicated chart. It looks simple, but it's not. On the vertical axis, we see healthy life expectancy, and we're still comparing the same 10 countries to the United States. We see healthy life expectancy on the vertical axis. And on the horizontal axis, we're not seeing money or years. Excuse me, we're not seeing years. We're seeing how much money is spent on healthcare. And as you can see, the comparable countries got to much higher life expectancy, and their spending was way lower because they're on the left side of the graph, whereas the United States went out to the right side. Now, but this graph is interesting because it adds a third dimension. It adds the date when these health results were achieved. And if we draw a line, this is before the COVID started. If we draw a line in the United States, when our life expectancy was approximately, call it 76 or 7, the United States was here. When the other countries had a life expectancy of what ours was in 1997, they achieved that life expectancy, our life expectancy in 2019 was the same as the other country's life expectancy in 1997. All the money, all the innovation, all the great discoveries, and the United States didn't catch up in life expectancy to the other countries. From 1997, we didn't catch up until 2019. And when the other countries were achieving that life expectancy, they were spending approximately $2,500 per person on healthcare, and we were spending almost $11,000 per person on healthcare to achieve that longevity. Now, this is where it gets particularly shocking. This is in 2021, after 2 years of COVID. The United States is here. We're spending $12,000 plus per year on healthcare for everybody, and our life expectancy is approximately 76. And if we go back and find out when the other countries had a life expectancy equal to the American life expectancy in 2021, you have to go all the way back to 1986. So the health of Americans is now equal to what the health of the other countries, citizens of the other countries, was in 1986. And at that point, the other countries were spending $1,000 per person, and we're spending almost $13,000 per person. This is how ineffective and inefficient the United States' approach to health and healthcare is. Now, I want to take a dive. Well, first, let me say that Nobel laureate in economics, Angus Deaton, and Angus Deaton is the author of a book called Diseases of Despair with his wife. They're both economics professors at Princeton. And Angus Deaton, Nobel laureate, wrote in a review of a healthcare book in the New York Times, American healthcare does a poor job of delivering health, but is exquisitely designed as an inequality machine, commanding an ever larger share of GDP and funneling resources to the top of the income distribution. And that's because those people are the ones who are investing in healthcare and making private equity investments and direct investments in healthcare, so that the money that they're making is being taken from working Americans. And in my book, Sickening, I start out the introduction by explaining that after the first 9 months or so of the vaccine, the COVID vaccine, being used, and thank God it was available and it saved many lives. But after the first 9 months or so, the 17 billionaires had made $50 billion in profit from the vaccines. And at that time, the World Health Organization, the IMF, and the World Bank were begging for $50 billion so that they could distribute vaccinations to the third world. And they didn't get the $50 billion that the billionaires had pocketed. So this is a perfect example of how healthcare serves, healthcare innovation serves as a way to redistribute wealth upward. So what's the primary goal of American healthcare? And if anyone has a better answer than this, please let's talk about it during the comments. But I think a good approximation of what the primary goal of healthcare ought to be is to maintain and improve individual and population health most effectively, efficiently, and equitably. So this raises two questions. If that's a reasonable statement of the goal, why are we failing so miserable on the achievement of this goal? And the second question is, why are doctors and other healthcare professionals willing to go along with this dysfunctional system? Like the doctor that I spoke to in the ICU while I was having my functional stress test to see if my conversation with him would set off my ventricular tachycardia. So there are a lot of problems here, but the four problems in American healthcare account for about 2/3 of the difference in spending between the United States and the other wealthy countries. Number one is pharmaceuticals. Number two is expensive procedures. Number three is administrative costs. And number four is imaging procedures. But pharmaceuticals are the greatest cause of the rising cost of American healthcare. And now I want to narrow this talk down and say that the primary problem in this part of the issue is that the drug companies and other commercial interests have captured what doctors and other healthcare professionals accept as medical knowledge. It's not necessarily true, but it's what their education and training has taught them to accept as medical knowledge.